happy that you're here with us today. I am yours truly, Beatrice Caines. I'm your host on behalf of the Independent Funeral Directors of Florida for today. This is our 45th Straight Talk Continuing Education webinar since we began the series back in August 2020. Me oh my, that's a lot. 45. Woo! Some housekeeping rules in order to qualify for the continued education credit. You must be an IFDF member. You can either be a firm, an establishment owner, individual member, or an affiliate. You must be logged into class here at Zoom using your full name in order to get the full credit, and you have to remain logged in. So there's no skipping class. I'm sorry if you have to use the restroom, but you can hold it. We're okay. And upon the conclusion of this webinar, please forward your license number to Heather. I will copy paste her email address here for everyone in the chat box so that you can request your 1-hour CD credit certificate. At the end of today's presentation, we'll take all Q&A. You can post it in the Q&A box on the bottom of your screen. And we will be monitoring both boxes throughout the presentation as well. We encourage you to ask Dr. Schultz any and all questions because he loves questions. Also, I would like to thank you all for having me as your host throughout this time. It has been an honor and pleasure, and I can't wait to ring in the 2025 with you all once again. And so without further ado, I'm excited to have Dr. Daniel Schultz here with us today to talk on the autopsy and introduction for funeral directors. It provides participants with the expertise and the necessary skills to mitigate the concerns that arise when having the conversation with families as well, who have to deal with the unfortunate experience of their loved one being an autopsy case. You will be able to explain to them the background of what a forensic pathologist is versus a general pathologist, as well as some understanding external factors like the environment and how that'll accelerate the process of decomposition. We love those decoms, don't we? This will also give us some insight on special autopsy techniques and why they might need to be performed on certain cases versus others. Dr. Schultz is the founder and president of the Autopsy Doctor. This straight talk is a personal favorite of mine since forensic pathology and toxicology were my first love prior to going into the funeral industry. I previously had the privilege to working with Dr. Schultz and witnessing firsthand his expertise on these cases, as well as relaying the results to already sensitive families. Welcome, Dr. Schultz. Thank you for being here with us today. The floor is yours.
Thank you. Thank you. No, it's a real pleasure to be here. I really enjoy this group. Marcy and I started going to your meetings a few years ago when I retired from my regular day job. And part of the reason initially was just to get to know you all, because to be honest with you, the referrals I get in private autopsies tend to come from funeral directors. They sometimes come from MEs, they sometimes come from lawyers, they sometimes come directly from families, but to be honest, you're the stakeholders who actually, uh, they ask, and most people have no idea. And even if you go on the internet, you would have no idea how to get an autopsy. So today I thought it'd be a good opportunity to talk about it. Oops, here, I moved my screen. So a little bit of disclosure, obviously I own a private laboratory, so that's what I do for a living now. I built a lab about 10 years ago, having worked two jobs effectively for almost my entire career. So I'm retired as a medical examiner, worked most of my career in Sarasota in District 12, trained in District 13, worked in District 13, worked briefly in District 6, covered for 22 and 21 occasionally, like most forensic pathologists, kind of helping out as need be. I'm from Michigan originally, and I trained originally in Wayne County and at Oakland County, at Beaumont Hospital, but I worked and trained in Wayne County and Oakland County. And then I also had a laboratory in Bacasta County where I served everywhere between basically Grand Rapids and Traverse City a few years ago. And in Ohio, I was there. That was where I started my career after fellowship in Cincinnati, taught at the University of Cincinnati Medical School, College of Medicine, that is. I actually did a little teaching with Cincinnati College of Mortuary Science, doing private cases once in a while. But all told, I've been doing this for 34 years. I've done over 7,000 cases, and I say over because I don't count any longer. But nonetheless, I've done, hundreds of death investigation consults. I've gone to probably, well, not 1,000, but hundreds of death scenes. So in every jurisdiction I worked, but for a few rare places, Cincinnati in particular, Tampa, Sarasota, Clearwater, I went to homicide scenes. I went to baby death scenes. I went to, work related scenes. I that was the thing I enjoyed. I like going to scenes, and I also like the conversations I have with families. It's one of the reasons I chose to do forensic pathology. I was a teacher as well in teaching in the forensic pathology fellowship program. And another side of me that is opposite side, interestingly enough, is I worked in transplant. So I was Lifelink's medical director for 16 years and overlapped a little bit. I was medical director for Lifelink and LifeNet Health in Virginia Beach for a few years. And then I ultimately retired and I was the president and chairman of the American Association of Tissue Banks for a couple of years as well. So I have some background in transplant. I'm not going to talk about transplant today, but the point is, those of you who meet me know me at meetings or wherever. If you want to ask or you have a question or something didn't work out so well and you want some advice, I don't work for anybody anymore. I just work for me. I can answer a question. I don't have any vested interest. So over the years, I've seen some really cool cases. And one of the reasons I retired is that I was getting all these cool cases. And unfortunately, I had to say no a lot because I had a day job. Now, in 2015, while I was working two other jobs, I got called by the History Channel and the US Marshals, and I did an autopsy on the brother of the two men who escaped from Alcatraz. And the show, which was on the History Channel, was called, and is called, it's still on, Alcatraz Search for the Truth. And if you look in this right upper corner here, this is Alfred Anglin. Alfred was also in prison in Alabama, and he also tried to escape, but his brothers were at Alcatraz at the time. They'd already escaped. And he was definitely a certain person of interest as they were trying to figure out where those guys went. Alfred, when he tried to escape, reportedly climbed through a window that was electrified and he died. He died about 6 months before I was born in 1964. Well, over the years, the family thought he might have been beat up. They thought, the US Marshals did something to him, but they really couldn't afford a private autopsy. He was buried for 50-ish years. And then when the History Channel got me and the US Marshals interacted with me, they offered to do the autopsy for free. I was paid, but paid by the History Channel to do the autopsy and exhume him. And so we did. And the show talks about it, and I have full permissions to talk about every aspect of it. I was able to keep all the photos and the video and this and that. Very cool case. Can't expect to be doing those cases when you have a day job all the time. Back in 1995, I had the Glenn Rogers case, referred to as the Casanova killer. Last woman he killed was in Tampa, and the Tampa 8, which interestingly enough was right next door to where I stayed when I came to interview for fellowship. But he was sentenced to death, and he's currently in death row. Amber Lee was a young woman who was kidnapped down in Northport, and that was one of mine. It was a scene exam, an exhumation. She was buried by the individual who killed her. Stephen Smith, if you've seen anything on Netflix about the Murdaughs, well, Stephen Smith is a young man who was found on a highway. That is the topic of that show. He was sent down. The South Carolina SLED law enforcement team came to my lab in Tampa with Stephen, and we did a second autopsy on him. So we've seen some cool cases. I have a high regard for yourselves as funeral directors. And in fact, roughly a month ago, I gave a talk in the Caribbean Forensic Sciences group. One of my talks I gave was on respect for the dead and funeral professionals. Basically, what I was talking about is dissection tips, things you need to be aware of, things you don't want to do that could affect the funeral director, how to appropriately dissect the neck, all sorts of things like that. I just wanted to share that with you because I'm not just saying it. I say it and I do it. So funeral considerations. This is what I told them. This is a slide that I gave them. One, never mind what you're told about disposition. It matters not if they're going to be a direct cremation because they will change their mind. Treat everyone as if they're going to have this fantastic Lady Diana viewing. It does not matter if they're decomposed. I still stay away from anywhere that'll show if I can because they do change their minds. And so that's a huge thing. And then also, there will be cases that need certain dissections that could cause problems, particularly if you're not familiar with it as a funeral director. And I told colleagues of mine that this is an opportunity to gain a collegial relationship. It's your opportunity to talk to them on the phone. A lot of times we don't have opportunities to talk, and it's really strong. Whether it's a complaint, maybe they experienced something that they didn't like, that's fine. You need to hear about it. Even a mistake, buttonhole, so to speak, or perforation of the neck, or short carotid. It's a chance to show that you care when you call them. I can honestly say that in 7,000 cases, I've only had one time that I perforated the neck, and it was on a person that had surgery in that site. But the bottom line is, I'm really careful. And if I did it, which I did in that case, I called the funeral director and say, "Hey, by the way, this is not normal for me, just so you know." Um, so what can change? Well, they change their mind. And again, as I said, even decomposed bodies can sometimes be requested to be seen. I'm sure you may have experienced this. When I was the ME in Sarasota, Hillsborough, we would get requests on really badly decomposed people to come and look at them. And that's always challenging. So the other thing I told the colleagues of mine is, speak at local funeral director meetings. In Florida, the medical examiners have input from the funeral directors on their overall performance. And it's really a good idea to have a collegial relationship. And every locale, every firm has different customs and experiences. You cannot assume that if you're, for example, I trained in Tampa, I worked in Cincinnati. Traffic deaths are like my thing. So I'm used to figuring out why people died. I never write things like blood trauma. I write why they died, like they dislocated their neck. And how do I find that out? Well, it's because I might need to do a posterior neck dissection. And I can tell you, if you've never seen one before, you might think we're messing with you to get that sort of thing. We're not. We only do it because we needed to. But that said, I will say most forensic pathologists don't do posterior neck dissections ever. So you could go your whole career as a funeral director and never see that sort of thing. But it is very relevant, and it does help figure out why a person died. So here's something I showed them. This is a real case, and we're going to actually look at this case later. This is a second autopsy. So mind you, the one on the left, the image on the left has been dissected a little bit by me. Like I've dissected this off. But for those of you who are funeral directors in the audience, this is a real problem because you shouldn't be seeing the carotid in this block of tissue. So effectively what happened here, oops, back up. They took out that entire block. And I can tell you, they did not dissect the strap muscles off. I did that. These were attached. It's just a giant block. We'll get into this later what this hemorrhage means, but I can tell you they didn't dissect it the first time, so they didn't see it, and it was relevant. But nonetheless, this is the problem that I want to address. Now, mind you, this is the same case. When I first started, and mind you, I'm here to basically prop everyone up. I want to show the good work that's being done. The problem is, I saw this and I said, wow, that's awesome. They tied off all these vessels. It's fantastic. But no, they tied them off down here. But up above, here's the carotids. They're nowhere to be found. So I really feel for the funeral director who had to deal with this one. And mind you, this is a woman I autopsied after she'd been dead for 7 years. Now, mind you, this is embalmed and fixed because it's in a bag of tissues that are also in fixative. So here's what it should look like. Now, I do this on every case, my entire career. Some pathologists, forensic pathologists, are shocked by this. They say, you do a layered dissection on everyone? I say, yes, I do, because it allows me to know where the carotids are and to stay away from them and to dissect the areas I need to see, which is the neck, trachea, the thyroid cartilage, the hyoid bone. So I can assess whether there's hemorrhage there. When they take it out as a giant block, which they did on that one I did a second autopsy on, they completely miss an opportunity to see the hemorrhage, which, as you'll see in the presentation later, is important. The one thing to know about private autopsies, and I'm not going to talk a lot about forensic cases. I'll answer any questions about ME, coroner stuff, other states, coroners, but I kind of want to let you know what an actual autopsy is like. So you're going to walk through an actual autopsy with me. Now, know this. Most private autopsies have overtones of trauma because families will think there was trauma or possible injuries that need to be addressed. And when physicians who assign death certificates sign them, to be honest with you, they have no idea what the person died from. So it's generally a probable thing. And that's okay. That's what their mission is. What's most probable? But forensic trained pathologists who do private autopsies, well, they're kind of important, and people want to ask the right questions because a couple things. One, they know when to report a death. Usually, you know that in the beginning, meaning the family says we think they're a drug overdose, and yet they were declined by the ME. And if that's the case, the ME does not know about the apparent overdose. Okay. Sometimes families do this because they want some sort of private thing that's going to disclose this, but they kind of keep tabs on it when they're talking to the ME. That has happened. So you got to know when to report. Or if you get a case that has trauma, hip fracture, drug abuse history comes up, you got to call the ME. That duty never ends. So if I become aware as a forensic pathologist of any sort of trauma, it could be 7 years later, it could be 50 years later, I have to call the ME. It's illegal for me not to do so. So one of my heroes historically, Milton Halpern, was referred to as the world's greatest medical detective. Milton, I shouldn't call him Milton out of respect, but the point is, Dr. Halpern said the only solution to really understanding death investigation is through day-to-day experience acquired by application, and it's in routine cases. It's not just the crazy serial killer cases, it's the medical cases, it's the suicides, the hangings, this, that. And if you don't do those things, or you sort of routinely aren't looking at those cases and doing autopsies, you kind of fall outside the loop and you don't really necessarily appreciate what you can see when you look. So you also want to go into an autopsy unbiased as much as possible. You don't want to cut short your completeness of your dissection by a preconceived, premature conclusion. So just because I see an enlarged heart, or just because I see a coronary that's narrowed, that doesn't mean that's why they died. I have to look at the big picture. In fact, not only do I need that, I need the history to help. So they're not very common these days. In fact, in 2019, CMS, which is the federal body that basically is involved with Medicare, decided that they would not fund autopsies any longer. So hospitals get no reimbursement for autopsies. The decline has been rapid for decades prior to that, but right now, essentially none of them do them. So for someone like me who actually likes to do them and always liked to do them, when I built my lab before all of that, it was one of the incentives for me to just say, hey, I should just do this. I really like doing this. Also, my accountant played a role in that because she said to me, she goes, you've been working 2 jobs and doing this on the side. You've been doing a sort of a lot for a little. She says, you need to do a little for a lot. And I said, wow, that's a good point. I mean, I'm not suggesting by any means that I just do this for the money, but the point is, there is a need for this, and there are people who do this, and I am in that cohort, that realm of costing that's similar to my colleagues, some of which have no board certification, have no real experience in this. So the point is, you want to have a person who actually has done this for a living for some period of time. And why are they even asked for? Why are private autopsies requested? Well, a lot of times it's concern over foul play, concern over a incorrect homicide call. Sometimes, somebody who's accused, maybe they get the court to allow a second autopsy. Maybe there's concern for medical malpractice. Well, probably the biggest category, which I'm sure you all can understand in the funeral industry, is family dynamics. Family dynamics are rather interesting when somebody dies, and oftentimes, particularly in Florida, it seems there's a lot of family that live out of state and haven't seen dad or mom for a long time, and dad and mom now have a spouse that's 30 years younger, and they die, and everyone thinks they murdered them. And so, to me, that's actually a big share of what I get, believe it or not. But the most common reason ultimately is just what happened. What happened? So I want to show you what my lab looks like because I think you have no idea. In fact, I will say, to my knowledge, mine is the only lab like it in the United States. I know forensic pathologists who do private casework. I know forensic pathologists who work in privatized systems where they're allowed to bring them in. But this is my lab. I built it. And so, I have a platform. I weigh everybody that comes in. They're measured, weighed. So we verify things. This is a very clean, respectful room. It's super clean and respectful, and that's the way it needs to be. Look how bright it is. You can imagine back in the day when I would do them in funeral homes, which the nicest funeral homes in the world are still really not set up for an autopsy. So I definitely I knew I needed something like this. My colleagues around the country told me, "Oh, funeral homes will never release cases to you." And I said, "Well, I think that when we come in their funeral homes, we probably create a bit of a mess, a bit of a distraction. We might tie up a room. I think they'd be okay as long as we're transparent. We explain the process." And having done this now for 10 years and doing about 130 cases a year, I don't have any real snags at all. Transportation's always the biggest challenge, but we work with the funeral home, whatever they may choose to work with, and we schedule accordingly, and it's worked out quite well. So this is the autopsy room. This room is storage where we wash towels and what have you. These helmets, these are product of COVID. When COVID started, I invested in these 3M PAPRs, which are powered air respirators. These effectively filter organic vapors, and they're awesome for decomposed bodies, and they're awesome for embalmed bodies because you smell nothing, nothing. They're fantastic. So my tech who floats around me, I do the dissection, by the way. They help, but I do the dissection. My photographer stays clean. They may input data into this computer. They will take notes. I will yell things to them. But we're all in these helmets if we're doing cases like that. If it's a normal case, we're just wearing masks and the usual PPD. This is my entryway. I like to teach, so I have fellows have rotated with me, medical students. So there's a poster here on the side. This is kind of like a dentist's office. There's a private bathroom. There's drinks. There's popcorn. There's food. It's like a vending machine, so to speak, with no cash needed. Because we have delivery service from the entire United States. We have cases flown into Tampa from even outside the United States. And then they can get a drink out of here, have a coffee, and it makes it very convenient. Most don't stay and wait. So most we give them a call later and tell them when to come. So that Alcatraz case, this is back in 2015. These guys were on the show. Oopsie. Those guys were on the show. I was on there briefly. They showed me doing the autopsy. This is Nick, one of my assistants. This is Alfred Anglin. This is 50 years after he died. He's still in his brown polyester suit, which, as you might know, polyester does not go away in the elements. So it was still perfect. He still had his glasses on. His hair was still combed. And oh, I'm sorry. And so anyway, we were able to do a complete autopsy on him. So the first case, I'm just going to talk to you first about the traditional cases we get, which is a natural death. But there's questions about malpractice. There's questions about did somebody hurt them, and the usual family dynamics. So we'll start with this case, and I'll show you kind of how things flow, how it works. This is not the way it's done everywhere. I take more photos than anyone I know of. It's one of the reasons that I was a little bit ready to leave the government work because, as you can imagine, when you're doing many cases a day, you can't take all these photos that I like to take. So in my office, I do what I need to do, and I do not have a time clock, and the staff get paid by the hour. I don't, but I want to get it right. So we take our time. Pardon the bubbles here. That's because of this background. I gave a drowning talk, and I used the same background and realized it, but I have covered everything up. And mind you, you should know, every photo I'm showing here has been not only signed off, acknowledged, requested by the family to be used for teaching. That is the key. This woman's family wanted her to be an example for me to teach others. So just know that. And I obviously cover up any identifying features, any problematic areas, genitals, and what have you. But the point is, I want you to show the kinds of photos we take. So we do it like this: thirds from the front, the middle, the bottom, from the side, right side to the bottom. Mind you, she has this large bruise. Now you can imagine from the family's perspective, even funeral director, what the heck? Did she get a hip fracture? What's going on here? Nobody really knew. She has natural disease history. The ME declined, but is this true trauma or not? Well, you only really know by looking on the inside. So lots of photos. Left side, feet, middle, head. Every place is photographed. Every case I do has well over, on the average, over 100 pictures. Every case. So even just presence of ear piercings, her eyes, her conjunctivae, her dentition. I want someone else to be able to look at my work and judge it. I want them to be able to create my report if I got hit by a truck. This family has paid a good amount of money for this exam. They're going to get this. And so the photos are better than anything I can write on paper. Yes, I write it on paper, but it's all backed up by documentary photos of what I do see and what I don't see. So here's her hip again, side. There's her hand. She's got a little bruise on her finger. Everywhere. These are some were actually left out in this, okay? But there's a lot of pictures. Now you see this sort of thing. What do you think? Well, maybe that's a handprint, right? Fingers, perhaps, right? It's unusual looking. Now, I apologize for the picture of an anus here. And there's a reason for it. It's because there's blood coming out of it. Why is it relevant? Well, she's got a little bit of terminal GI bleeding. What you don't know, this is her bruising. This is showing her back, the external features. So her entire body is shot. So she's got a lot of blossoming hemorrhage. So it's inside that counts. Now you're going to see step by step, closer shots. What I do on every single case. I just pulled this case out today. I randomly grabbed this case. This case is educational authorization, as every photo I shoot, every single case. And the first one is in situ, meaning it's everything as it is when I open up. Now, what's the value of this? Well, the value is I can corroborate she didn't get CPR. She doesn't have any hemorrhage. She doesn't have any rib fractures. She doesn't have any bowel hemorrhage in her peritoneum, that sort of thing. So I lift the chest plate off. I don't see any hemorrhage. I don't see any fractures. I see lungs that are inflated. They're pink tan, a little bit of soot, but that, according to the family, she never smoked, and this is probably just from living in the city. And then I take a picture of the rest of the abdominal viscera. Now, when we open the heart, we always take a picture inside. And what do we see? Well, we see the heart. The aorta is a little collapsed, the pulmonary artery. We've opened up the sac. Look at what the fluid looks like. There's the liver. There's the stomach. Stomach's full of air, a little bit. Here's your bowel, just showing that it's been lifted up. So here's the transverse colon, mesocolon, small bowel. Everything looks pretty good. What don't you see? Well, you don't see any internal trauma. That's key. Now, what's the bowel contents look like? Well, we take pictures of everything. Here it is. This is from the proximal jejunum. So if she had a GI bleed, a duodenal ulcer, something like that, it's going to be bloody. It's not going to look like this. This also tells us that the gallbladder is working. This is the appendix. We always take a picture of that. Why do we do that? Well, it's an identifying feature. So sometimes you can imagine if you say there is an appendix or there isn't, and the family thinks it's the other way around, having that photo is kind of nice. This is the thyroid gland. It's been dissected off. You can see this nodule here, little nodules here. These are colloid cysts. Turns out this person also has Hashimoto's, but nonetheless, these are colloid cysts. This is just showing what the body looks like after we remove. Now, mind you, this person's been on steroids a long time. They have rheumatoid, they had Sjogren syndrome, autoimmune processes. So they've got some scoliosis. See this little curvature of the spine? That's really the point of showing that. The other thing we see is the abdominal fat pad. I measure that on everybody. I don't take a lot of notes during my exams because I take a lot of photos. When I'm typing this up, I get to look at the photos. It's a lot easier. A lot of times people will say that, or at least clinicians will think people aspirated, and usually they don't. This is just showing the epiglottis. This is the hyoid bone up here. This is the trachea and larynx. Point is, there's nothing in it. They didn't aspirate. I do that at every single case, and I can tell you it's good because when they say that, I can at least defend that they did not, or they did. Here is an aorta with some severe atherosclerosis. This is her aorta. Kind of looks like a Gino's cheese pizza, which probably is from eating Gino's cheese pizzas. But anyway, it's normally should be nice and smooth, but it's not. It's kind of got these ulcerative areas. The black discolorations are just from plaque hemorrhages and what have you. This is the vena cava. The liver's over here under the diaphragm. Here's her bone marrow. Now, this is a vertebral body that's kind of short and not so tall. This one next to it, this is a compression fracture. And this is old, but she's on steroids and she's older. She's postmenopausal. So she's got osteoporosis. Look how fragile. If I were to push on this with my finger, it would just crush because of the osteoporosis. Here's her stomach. It's just showing what's in there. bilious fluid, brown fluid, no pills, no granules, nothing like that, no blood. Again, every photo has a reason. Lungs, inflated, a little bit of black pigment, this stuff out. Shoot. I'm gonna not take this. Hold on a sec. Sorry about that. Apologize. I'm actually on call today, so I apologize for that. They can get back to me though. This is what it looks like on the other side. I open up the pulmonary arteries to look for pulmonary emboli, and there are none. That's always good because that's something someone can die from, a pulmonary embolism. This is the cut surface of the lung showing the parenchyma. This is the top, this is the bottom. There's congestion, kind of fluid. She's got some heart disease, which we're going to see. There's her liver, there's her spleen, there's her kidneys. Kidneys are a little bit finely granular. That's consistent with hypertension. These coarse granules are from some previous urinary tract infections. This is what it looks like when you cut it. Normally, the cortical, you can see what a centimeter looks like here. It's kind of thin. It should be out to here. Whoops. This cortex should be from here to about here. It's not because of hypertension. This is what happens with hypertensive disease and can sometimes cause renal failure. Here's her bladder. There's some blood in here. It's distended chronically. She's had chronic urinary obstructive issues. It's not why she died now. She has no pus in there, but point is that's that. These are the photos taken every single case. This is her brain. She's got plaques in the basilar artery, quite typical of hypertension. They're not obstructive, but she's got plaques in the carotid on the right. We also flush the carotids from down low to see if they're patent. We don't cut into them, but we shoot water into them and flush them. When somebody's up at the head looking to see if it comes inside, and we know those vessels are open. So we do a sort of around the world on the head, on the brain, so to speak, to see if everything looks okay. And in this case, it's pretty normal looking brain. That's the substantia nigra and the midbrain, a little close up. If someone were to have Parkinson's, that wasn't her story, but nonetheless, I just want to show you. This would look really pale because those neurons tend to fade away in Parkinson's. Here's the brain cut surfaces, kind of like a CT scan. It's effectively normal. These blue backgrounds I use on every case. They're basically chef's cutting boards, but they're really good for a good, clean, crisp pictures. Here's her heart, front and back. Here's her coronaries. I dissect them. I look at them from a distance and a close-up. That was the left anterior descending. This is the left circumflex. You can see they're open. This is the right coronary artery, and you can see it's open. This is what's called bread loaf technique, where you cut from the apex, sort of in a plane that would essentially be a horizontal plane. And what we see here is this old aneurysmic dilation from an old heart attack. That's what this is. It's cut here, and it's very thin, it's fibrous. Now, mind you, she doesn't have bad coronary artery disease, so presumably she had spasm in the past, but she's had a heart attack before, and it's an old one. And that's, her primary issue now. This is just showing her wall thickness where that infarct was. This is the aneurysm. It's effaced like a balloon. This is her aortic valve. It's not problematic. I don't see any obstructions in the orifices. I always take a picture of the cassettes I take in case the ink falls off. And yeah, I've covered up all the names. But the point is, if the ink comes off these, I know what's what when I get them back because I can match them up to the way they look here. This is sort of typical of her histology I might take. So we've got, for example, here, this is the atrioventricular node. This is the infarct area. The bone marrow is here. I take bone marrow on everybody because if they have a leukemia, lymphoma, I won't see it unless I look. Here's tox. Do I do tox on everybody? No, absolutely not. Do I take it? Yep, always, if I can. Sometimes you can't. They're decomposed, second autopsy sometimes. But I take it because sometimes I don't find anything. Sometimes I need this. So I restore, I keep it, it's frozen, and we keep it for 2 years. So pearls on autopsy diligence. Well, you need to have a well thought out plan that addresses future relevant questions. That's why I take so many photos. I don't always know what's going to be asked later on. I don't usually know the full picture. And I can tell you as a medical examiner, most of my career, I I didn't really appreciate some of the sort of bravado that I think some of my ME colleagues have about how fast they can do autopsies, or they can do an autopsy in 20 minutes. To me, you don't brag about doing an autopsy in 20 minutes. Okay. That means you didn't look very hard. And that to me says something else. And I'm just saying, I take a lot of time on my cases, sometimes 2, 3 hours. It depends what the case is. Whatever it needs is what it needs. I don't charge more for that. I just need it. I do it. So the end of the story on her is number one, that hemorrhage, she's on Coumadin, she's on Lovenox, she's on anticoagulants. Why? She has atrial fibrillation due to her heart disease. Her heart disease is what killed her. That's just an effect of her cutaneous fragility and her anticoagulation. You can see there was nothing deep to that. So sometimes what you see on the inside, she's on steroids. How did that affect? Well, she gets the bony effects from that. Steroids also increase blood pressure. They may change glucose issues, affect hyperglycemia, a lot of reasons. So again, what did we do here? We answered a question that would never have gone away if this person was cremated, buried, and nothing ever happened. They would look at those pictures, perhaps if they saw one at a funeral, and say, Grandma was beaten. That may never go away. And that's the whole point behind it. We spent a lot of time explaining what the relevance of an autopsy might be, whether it's a good idea or a bad idea. We talk a lot of families out of it. And if you've ever referred a case to us, you may find that out, that they say, hey, final diagnosis was called, and Marcy talked to them about the case. Dr. Schultz may have talked to them, and they said it really wasn't a good idea because the question they had, like, for example, what's our risk factors? Well, they already knew they had bypass grafts. They already knew they smoked. They already knew they were 300 pounds. They already knew they had a variety of things. I'm not going to answer that question. I'm going to answer why they died, but is that really going to change things? No, it's not. So we don't take those cases as a rule, typically, unless there's something to be shown. This is a cool case. So this is the kind of thing you think about for forensic pathologists, which they don't necessarily deal with. In fact, most medical examiners, they never see these sorts of things. Why? Because they've already autopsied them the first time. And if they do a second autopsy, it's because the case was done in their jurisdiction maybe decades prior, and maybe they're asked to look at them again. This person came to me from another jurisdiction, and I'm not going to mention any names because it doesn't matter. But the point is, this was a young woman who died 2016. She was in a pickup truck with a man. They were in a lake that had backed up into the lake. It was in reverse. I'm sorry. It's backed in reverse, as you can see, but it's in neutral. And there it is being pulled out of the water. This is how they're found. Now, obviously, they're dry now, which means that the FHP took a little while investigating this, because by the time the ME investigator got there, well, they're pretty dry. So I suspect they laid out there for quite a while. But look at how they're positioned. His hand is defying gravity a little bit. That's not normal. If you're laying on your back and you're dead from traffic, you really shouldn't have your arm hanging in the air like that. Likewise, what the heck's going on here? Why is she laying on the floorboards, hands across her chest, hands across his chest? To me, I was asked about this from the sister of this young woman, who, for the last, at the time, 5 years, had been told that she died from drowning. They did an autopsy after this, and they said both of them died from drowning. Accident for both. She has no drugs in her system. She has no trauma whatsoever after their full autopsy, and yet she's dead laying on the floorboards. To me, this is a common sense case. I did a pro bono consult. I was so concerned about this, and I knew they couldn't afford it. And I do these once in a while. I don't do it all the time because obviously I have a career. But the point is, I knew that this was likely to be something more sinister. So I did that. I wrote a consult, went out, and subsequently, they didn't act on it. So she's, again, oh gosh darn it, sorry about that. Here's the gentleman in the car with her. Now, it was told to me by the ME involved later on that, oh no, his arm's raised because there's a coffee cup under it, and that's why his arm's in the air. Okay, maybe. What's interesting about him is he's got a syringe tucked neatly in his pocket, and he happens to have methamphetamine, but he signed out as a drowning with methamphetamine contributory. Neither one of them had been, well, till this time, they're both buried until I did that consult. So months after she was signed out as an accident, or at least during the process of that, the family was concerned They asked them to do a recreation. Now, why they sent the truck in forward, I have no idea, but they did. And they put it in the water, and it took 2.5 minutes for it to sink. Mind you, this is the way it was positioned when it was found. Now, when they let this go, it was basically just sitting on the edge. You put it in neutral, and it rolled to basically the same position. So it obviously was just rolling in under low power, just on its own gravity, and to end up there. 2 minutes, 35 seconds. She has no trauma whatsoever. The windows are manual. She could escape. Why doesn't she escape? That's why it's not a drowning. That's why it's not a drowning. The autopsy honestly can be totally negative. It's still a problem case. So I got, had a conversation with the local ME and the prosecutor and this and that. And basically, I was kind of made to look as if I was some guy who reads novels too much. And they said, no, we think it's a drowning. And subsequently, nothing happened. And so another year goes by. And I was in conversation with her sister, who was still distraught about the whole situation. And mind you, this is from the scene. These are her eyes. So she's got these little red marks here. Those are petechia. Those really shouldn't be there. That's a problem. Now, there's a little bit of tache noir, which is drying artifact, this sort of banding area here, which the local ME said wasn't there and said nothing was there. And he's already after this. So I don't know what to say about that, but I was concerned about this because sometimes you can get those from compression of the neck, for example. And there it is a little closer. So again, I'm concerned. A year goes by, I reach out to the sister and I say, listen, if you can get her to me, I'll do her autopsy as well, pro bono. I do have to pay my staff. I do have to pay for things. So there was some costs associated with that, but my personal side of it all, I didn't get anything. But again, I just felt so concerned about this case. So a letter was sent to the family after my initial consult. And basically, this was kind of shocking, but nonetheless, they wrote to the family and said, having looked at the evidence in this unfortunate case, there remains unanswered questions for which we cannot know the answer. One, if this is a homicide, who did it? Well, I can tell you that as a forensic pathologist, I never point fingers at anyone. I have no idea who did it. I just know it's a homicide. And so that's a kind of a pointless question that generally does not get addressed by a forensic pathologist. Is there evidence that shows behind a reasonable doubt that these deaths were criminal homicides? Well, yeah, they don't look like drownings. First of all, there's a problem. They need an investigation. They had not gotten an investigation. It was only a traffic investigation. And then they said, if a suspect could be developed, how did that person do it? A variety of ways. Let's just say that. What evidence can we present that the suspect, whoever they may be, actually caused a homicide? Mind you, this is 5 years after or more after the fact, where all I'm suggesting is that they need to investigate. And no time did I say, look, you got to dig them up to do a second autopsy. What would evidence suffice? What evidence would suffice to show that if anyone could be charged, committed murder behind a reasonable doubt? Well, we're going to get to that. So again, their initial conversation, which I also referred it to another pathologist who also looked at this case, and they wrote, at best, the only evidence, in quotes, that this was a homicide is a speculative testimony of two pathologists. Neither one can answer the hard question of who, which we never can answer, how, we also never can always answer, even though we know it's not accident, or why these victims were killed. We'll not know that either. While I appreciate their insight, this will not suffice to make a criminal case. And then they try to pad it by saying, well, we're sorry about your loss, blah, 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 but nothing happens. Another year goes by until they send her to me in Tampa. So here she is, 7 years later. You can imagine there's a lot of them, even the makeup, believe it or not, that white material on her face is mostly makeup. And you're going to see why it's probably just that. It's not just, some of it's mold, certainly, but we're going to progress through this. There's her garment she's wearing. She's kind of got a union all on down low here. Little flower thing in there. You undress her slowly and you see this union all. And then she looks terrible on the outside. But as I tell my ME colleagues who will say, oh, there's no point doing an autopsy on someone dead 7 years. I said, no, I've seen it. My eyes are open, but you never know till you look. So here's what she looks like after we move along. That's what she looks like then. This is what she looks like when you clean her off. Well, there's the original autopsy incisions. Yeah, her skin's not got the dark complexion elsewhere because it's slough, and that's normal, but that's her. And by the way, this family wants me to show this case because this case is thus far not at all been investigated above a traffic investigation. But here she is. So we're going to photograph the whole body. She doesn't have any external trauma. She's got eye caps, of course, because there have been funeral directors involved. Her eyes are, and you can't really say much about here, but I still photograph it anyway, about her, conjunctiva. There's her lower conjunctiva. Again, 7 years after death. Her teeth. Why did I make an incision into her lip now? Well, there's a lot of artifacts. Drying. I can't see hemorrhage with my naked eye very well, so I make incisions. I take samples. I look at it in the microscope. There's her lip again. Again, it's darker. Well, that's normal. The lip has a darker discoloration. Her neck. One might look at this and say, oh my goodness, this is some sort of trauma. Well, it is not. It is postmortem changes here. I made incisions just to be able to better evaluate it. Now, this is what we see when we look inside, and maybe in the question and answer, if some of you know what this specific material, is here, you tell me. It looks like sawdust. I suspect it's a drying agent, but nonetheless, it's there. There's the sternum. There's the interestingly enough, down here is a bunch of newspapers from years prior. Interesting, but that's what it was. Her neck structures. Remember that case I showed you where the carotids were completely cut out and they were tied off? That's this one. There's nothing in here. It's all been taken out as a giant block. That's just showing after the sternum's been lifted. These nicely tied off carotids and subclavians look fantastic. Doesn't mean a whole lot when you've taken the entire neck structures out. So it was a little bit, I was shocked to see that they did that, but nonetheless, there's the newspapers. They're showing her lack of trauma to the spine and to the ribs and to the pelvis. Those are those neck ties that I told you about. This is the pelvis. Again, this is nice. They tie these off here. I don't routinely tie these off. I usually cut it high so you can see all this. Likewise with the neck, I leave them long. They come down almost, if not all the way to the aortic root, they're way down here. So, and they're still ensheathed. Okay, so this is just showing the ribs are okay. Ribs are okay. Throat looks okay. There's her back. No trauma. I make these incisions, much like we do in prison deaths. Make sure there's no trauma. Things get hidden. So I make these incisions to document the lack or presence of trauma. This is a posterior neck dissection. Mind you, she was in a vehicle. I know she's laying on the floor now, but I don't know the dynamics. And I do know, as a forensic pathologist, that you can have neck trauma that isn't seen from an anterior approach. This is why we do posterior neck dissections. If I were to find hemorrhage here or an injury, it might explain why she's laying on the floorboards deceased, why she didn't get out of the vehicle. So this is why I do this. This is just showing the cord normal. That's her spinal cord 7 years later. No trauma. This is the bag of organs. As you can imagine, there's a viscera bag here that has a bunch of organs. And when you sort them all out, you can still look at everything. Here's the liver. Kind of looks tan, kind of like in med school when you look at embalmed bodies, similar. Here's the kidney, spleen, heart. This is the lungs now cut. I cut them to look at them closer to evaluate. I will tell you this about drownings. There is no diagnostic feature of drownings. A drowning is a person in water that you don't find a better reason for them to be dead. And that is the honest truth. That is the truth. There is no specific thing like if you see water in the sphenoid or you see water in the airway. Guess what? If you die and you're underwater, you're going to have water in those places. Doesn't matter. So there is no diagnostic feature. So anyone who says that, which this pathologist didn't know what they were talking about. So here's the neck that previously was not fully dissected. So here's the upper aspect of this airway. This is the block as I got it. And it looks just brown tan. You don't see any hemorrhage because things are buried underneath this. I had to dissect those off to find the hemorrhage. This is the bowels. As I find with many of my colleagues, some of them never open bowels. I open them all. This is the small intestine. This is transverse colon and descending colon. This is the bowel opened. Nothing to see there, but nonetheless. Now, What's the problem here? Oops. Inside here is hemorrhage. It's over the thyroid cartilage, just below the hyoid. That should never be there. It's not an artifact. It was completely covered by intact muscle. It's not an artifact of dissection. It's not any of that. It is trauma. And so, in fact, when you look from above, here's the epiglottis, here's hemorrhage in the area epiglottic fold. You can see this is the other side, which has no trauma. And again, here's the hemorrhage in the neck. You can see it on the neck high. So what does that mean? That's what you see when somebody's manually strangled. That is why I was concerned. Now, manual strangulation does not necessarily leave external signs. And so if you don't dissect these muscles off, you may miss this. And they did. So I found this and I put sections in to look at in the microscope. Here it is, hemorrhagic areas. And there it is in the microscope. Pretty well preserved, thanks to you guys in the funeral world. You preserved it nice. Here's this epithelium. Here's red cells, only red cells, no inflammatory cells. It's acute hemorrhage, hemorrhage. It's real. So what do I sign it out as? Strangulation, homicide, strangled by other person or persons. Now, do I know who did it? Absolutely not. Could it be the guy on the seat? Maybe. Could it be someone else? Maybe. Does that guy need an autopsy? A second autopsy? Yeah, he kind of does, because she didn't get a neck dissection. So this is where we are in this case. The family wanted me to show this. I showed this at the American Academy of Forensic Sciences. I showed it at the Colby meeting where I'm on faculty up in Maine. I've showed this to various forensic pathologists in Florida. Everyone agrees with me this is a homicide. Not one naysayer. And yet, to this day, in this jurisdiction, nothing has happened. And I really don't want to tell you where it was, because I'd rather have you not be biased and tell me, perhaps, when we're done, wow, did you agree with this? You think somebody should investigate this? Because it hasn't been investigated. So here's the best case ever. This case is a prison death, by the way. This is a 40-something-year-old man. He'd been in prison like 20 years. He went in when he was like 19. He killed somebody, so he's in prison for the rest of his life. But he's losing weight. He's 6'5". He's like 105 pounds. He's starving himself. He starts calling the family, telling about how the prison guards are injecting poison into his cell and their assassins are going to kill the family. And I talked to the family when they called me for a second autopsy. And I said, well, it sounds like he's delusional. It sounds like he has mental illness. And they said, well, he said when he died, he wanted a second autopsy. I said, really? A second autopsy? I said, well, why don't you let me talk to the original pathologist? And I pretty much know them all. And I have a good relationship with that pathologist. So I talked to her and she said, Dan, you need to do this second autopsy because they're never going to let me go. I didn't find anything, but he was really skinny. Looked like he starved himself. We don't really know why. We're waiting on tox. I said, okay, I'll do this autopsy. So what happens? These are in his colon. Okay. My tech, I opened everyone's bowel, right? Every single case. They did not open it because most forensic pathologists never do. So they're operating within the standard of care. But the point is, these are in his bowel. They're little chiclet-sized plastic wrap, you probably saran wrap from food, wrapped with probably a thread from the clothing. And you can kind of see it through this. There's some handwriting. You folded up paper. So there it is. I'm dissecting it. I'm dissecting it. I'm dissecting it. And it's a note written to me as the pathologist. He wrote this note and he knew he wanted someone to read this to explain that they were poisoning the food. There were assassins to kill the family. All these sorts of things that are clearly delusional. He's not on drugs. His tox was negative. So why did he die? Well, here's one of his quotes. Pieces of soap that become poisonous when touched by fluid. Toxicology will show exactly what I have been saying. Today is December 28th. All officials have been orchestrating this assassination plot. So about 2 weeks after I did this, I showed this at American Academy of Forensic Sciences. No one ever seen anything like this. And I kind of said to my colleagues, I said, listen, I know you guys think I'm compulsive and opening bowels on everybody, but I'm telling you, this case, if I didn't open the bowels, his cause of death would not have been determined. His manner of death would not have been determined. We would have had undetermined or determined. The reality is he's to starvation due to his psychotic delusional disorder of whatever cause, but it's natural. Thus, his manner is in fact natural. He did it because he thought that. No one did any of this stuff to him. He thought this was real. He ate these notes because he wanted someone to read and believe him. So again, best case ever. What else have I seen over the years? Some MEs I think have a perception somehow that they're the end of the straw, namely no one's going to look at their work. And I always, when I was younger, throughout the years, I wanted others to look at my work. I expected that. I would always say, "Bring it on," look at my work. So I didn't have a picture of this, but I got a case that one of my colleagues did it, works for me, and the ME who sent the case in knew it was police custody death, and they basically diced up the back muscles, like took him back in the autopsy room after they knew he was coming to us and did this, which was in my eyes mutilation, and it was an attempt to thwart our ability to do a second autopsy. So trust me, there are some bad actors out there that I don't quite understand, because I'm one of them, and I want only the best for our career. But the reality is, all forensic pathologists should be doing this sort of thing, in my opinion. These are the notes again. I'm going to bump up. So I know I'm getting towards the end here. I want to leave time, but I'm gonna just so second autopsies basically expect someone's going to review your work, and always expect someone's going to look over your shoulder. You should occasionally engage in private autopsy because it keeps your histology eye sharp. A lot of ME corner offices almost never do histology because if they feel the mission is satisfied, they just don't get on that path. That's not part of their mission. I'm going to jump ahead because I just wanted to show you the name position. The National Association of Medical Examiners is a body that creates standards. They are who most of us belong to. American Academy of Forensic Sciences is another. And they made a white paper explaining why second autopsies require full transparency between the original pathologist, those that follow. Likewise, the data I collect, I should share with them. The point is, we should share. And when I do an autopsy and someone hires me, I'm not there to tell them what they need to hear. I'm sorry, I'm not there to tell them what they want to hear. I'm here to tell them what they need to hear, which in probably most cases, I tell people things they don't want to hear. And the bowels, I call them the Rodney Dangerfield of internal organs. So I advise all to open the bowels. Now, I've got other cases, but I'm not going to show them because I know I'm rushed for time. What I would say is if you enjoyed any of this, I can talk ad nauseum on these cases. I teach at Colby, so I've got lectures already slated. And I've got some cool cases that I'd love to show, but I don't want to run over. And I do appreciate being asked to talk and know that I'm a member of your organization and I'm always happy to help on an educational side. I'm going to bop ahead. That one I'm not going to show, and I'm not going to show this because I don't have time. But I'm going to say, oh, crap. Sorry, guys. I went to the end. What I wanted to say is, I shouldn't have to do this. If you have students, your staff, who want to see an autopsy, if I have educational authorization, oh boy, Dan is sorry for this. If you have educational authorization on our end, we have people watch, and sometimes I do things just like this on Zoom. So I just want to invite you all to consider that. And I'm not going to do this. The point is, we can be reached at our lab in Tampa, and if you have any questions, we're in your member directory. And if you have any questions, let's go ahead and do that. I'm going to shut this off, by the way. There we go.
Any questions from our participants at all?
I know that went super fast, and I apologize. I'm a hyper dude, let me tell you.
All good. I do have something to say in my years that I've been able to uh, merge both funeral and autopsy, pathology, toxicology. And you come to realize that there's a huge misconception in society where everyone is going to have an autopsy done. And it's a common conversation during the arrangement with these families at the funeral home, in that not everyone has an autopsy unless you suspect of any sort of foul play. And I'm sure you've come across this multiple times when families call you, where they're pleading for an autopsy to be done, and really there's just nothing substantial there for you.
Right. And the thing with that is when they call us and they suspect certain foul play, I say, well, did you tell the medical examiner? Did you call the police? A lot of times they'll say no. So, well, you need to let them know. Here's the thing. If the person has compelling history, circumstances uh, of a natural event, and you just have like the brother in Ohio who thinks that somebody murdered them because it's their young spouse, that's not exactly enough evidence to then take them in as an ME case.
Right.
Now, and fortunately, I suspect if people know the right buzzwords to say, like I think they were poisoned and I know what, smart people perhaps, but MEs are going to say, have you called the police? If you haven't called the police, then we can't get involved because by all accounts, they have natural disease. And in fact, reasonably argued by the ME, if you have a person who, by all accounts, is a natural death and it's out of your statutory role, which in Florida is very well defined,
Mhm.
uh, it's illegal to take that case because the taxpayers pay for those, for them to take cases willy-nilly. And they will say, this is a perfect case for private autopsy, and then they will not just give them, they will have like a host of various providers, and they'll, in fact, my colleagues are extremely careful about not just saying, oh, send to Dan. No, they will just give them a bunch of numbers, whatever. And again, what's my point in even talking to you guys and being a member? So you kind of know about me, you see what I do. You don't always know that about their providers, and from a national perspective, those autopsies that might be provided, A, may not be done by a pathologist at all, might be done by a layperson. B, if there is a pathologist, they may not be forensic, they may not be board certified, they may not even be licensed in the state. Seriously, that's consideration. So there's a lot of questions to ask. And I always tell people, look, I don't want to say anything bad about any of the other pathologists. I want to say good things about me that I know, and that's kind of it. If you want to do it, fine. Yeah, the cost is going to be similar. I know sometimes others will be, couple $100 cheaper, this or that. But I always try to explain, well, why do I have costs? Well, one, we have a lab. We're the only lab like it. I don't just go to a funeral home. I have hazardous waste disposal. I have staff. So this is wise, but and there's no good way around it. Costs are there. But for me, honestly, when I'm doing a case, I always say this to my staff. I'm like, I actually can't believe someone pays me to do this because I like doing this so much. It's so cool, so interesting. Yeah, I can't say it's free for everybody, but every once in a while, a case is just so compelling to me. I say, I can't sleep at night if I don't do that case, that kind of thing. And then the others, most of them, it's that family member lives in Michigan, Ohio, worried about their mom and dad. They don't really have any evidence. And then you do the autopsy. And what do you usually find? Well, you usually find nobody hurt them. Sometimes you do find that somebody hurt them. And then you call the ME, or you find that it's a suicide or an accident because the family said, hey, can you do tox? And you say, really? You want to do tox? And then you get it back and they got amphetamines. So it's definitely a needed area. And yeah, like I said, we like what we do. We like being educators. And I think that when I was in Cincinnati, for example, when I would go occasionally up to the Dayton area, Cincinnati College of Mortuary Science, I think it's just in like Westchester, something like that. It was always kind of fun. I always liked having the mortuary science students in there. And um, I, you guys are like brothers and sisters to us in our world of forensics. Trust me.
Mhm.
Not a lot of people like us,
Yeah.
honestly, that can do what we all do. So, let's all be friends. Let's share. And if there's problems with things, well, share it. Let us know. Let me know if I do something that needs to be done differently. So, but I appreciate y'all for listening in.
Absolutely. Absolutely. Do we have any further questions? I'll check the chat. I don't see anything in the chat. So I'm going to go ahead and conclude our webinar for the day. Let me provide a friendly reminder to everyone that I have placed Heather's email address in the chat box so that you can submit your Florida license number so that you can get your CE credit for today's course. This is our last Straight Talk of the year. Please visit our website for any future events in 2025, which we have a lot coming up, as well as following us on social media. The 2025 events will soon become available in our calendar under the events tab in www.ifdf.org. Thank you so much, Dr. Schultz, for joining us today. That was an amazing presentation. It was like going back to my medical examiner days with you. And I also want to thank everyone for attending our Straight Talk series, not just today, but for the whole 2024 year. We appreciate the support. As always, stay safe, make wise choices, and we wish everyone a Merry Christmas and a Happy New Year.
Thank you all.
Thank
Appreciate
you.
it.
Take care.
Take care.